Now I want to talk about another thing. In the hospital, we see a lot, unfortunately, DVT and PEs. So I was actually pretty surprised. I learned all about PEs in medical school. Um, I really, didn't think I would see that many PEs. I diagnosed PE twice in the ED. Do you know how many shifts I work? I work 15 shifts. I see 6 patients per day. So that's what 90 patients. 2 of them had PE. It's a pretty, I don't know, it's probably by chance. And then I diagnosed someone with PE when I was covering nights. Uh, so it's actually much more frequent than I thought. So basically, with PE and DVTs, so if you have any suspicion this person might have PE, you should check for it. Because do not check a D-dimer unless you have zero suspicion for someone having PE. You do not check a D-dimer because almost everything else can make D-dimer go up. Then you'll be like, oh, what do I do now? So I know ER check for CTPA a lot. You don't have to do it. There's well scores and all that, but usually if people are high risk, prolonged immobilization, has active cancer, history of DVT, and then history of DVT, and especially not compliance with the anticoagulation, yeah, definitely you need to check for DVTs, check for PE. If someone was tachycardia, shortness of breath, recent trip, immobilization for like 12 hours on a plane ride or on a bus ride, yeah, you should probably check for that. I think the most common complaint was shortness of breath. They feel shortness of breath. They just feel like they can't keep up. They can't. Sometimes they don't even desat. Saturation looks fine. They just feel like they can't breathe. That's most common complaint I get from people with PE. The shortness of breath. Sometimes they have pleuric chest pain too. Sometimes shortness of breath and dyspneic exertion, pretty common. So ultimately, unless their kidney really sucks, really sucks, you should get, unless they're super fat, you should get a CT, pulmonary CTPA. You can always do VQ scan if CTPA is equivocal. But you should always just, start treating them if your suspicion is extremely high. I don't think I ever have to do that before, but because CTPA is super fast, so you can get it done. So when you have someone with PE or DVT, I talk about anticoagulations. You need to anticoagulate them right away. And if they have contraindications for anticoagulation, like massive GI bleed, hemorrhagic stroke, recent surgery, one thing you can do is getting an IVC filter. Even though I think with IVC filter is supposed to be on some kind of anticoagulations, IVC filter should be something temporary, not permanent. But with someone that has no other options, that's kind of the only option left is get an IVC filter. So in terms of lytics, I have never seen lytics being used. But I know that's being used because, none of my patients had lytics, but I do know some of my co-interns, co-residents, patients got lytics. So if you have a very robust IR service, they can put a catheter-directed lytics on patients that are hemodynamically unstable. So we're talking about people with RV strain, pretty much kind of in the right heart failure kind of picture. They're in cardiogenic shock just from not able to. Here I would say people with PE, they don't die from hypoxia, they die from, cardiogenic shock. There's nothing, going that way because there's too much pressure in the right ventricles. So, I mean, I know there was, I think on a Sunday, I was just hanging out in the ICU. I was not on ICU, but they got a patient who pretty much found down. But turns out that she had bilateral PE. So, when we say massive PE, it's really not, the massive itself, it's not a description of the size of PE. It's more of a description of how unstable the patient is. If they're hypotensive, that's probably massive PE. That would fit. You don't really, some people have pretty huge, clot burden, but they're hemodynamic stable. Then you don't even have to do, lytics. You just put them on heparin. It will be fine. So here's the PE and DVTs. The timing of DVTs, PE for anticoagulations, again, it depends. So if they have ongoing life, if they have, if it's clearly provoked and the trigger for PE or DVT was removed, if maybe 3 to 6 months is enough. But if you're like, say someone has malignancy and they continue to have malignancy, you should probably keep them on anticoagulations. Or someone with, let's see, one example I can think of is someone had a hip replacement and it was immobilized for 2-3 weeks and they had a DVT. Yeah, when they're walking again, you don't have to anticoagulate them anymore. But someone with, like I said, malignancy, or if they have, I don't know, ongoing risk factors, then you should probably keep them on anticoagulations. Or if it's unprovoked, you should probably keep them as well. So this is PE and DVT. Let's see what else I can think of. Okay, heart failure. You see that a lot too. So heart failure patient, you probably, well, it depends. Sometimes you do, but usually not. Unless, unlike AFib, RVR, or PE, patients do know they have a diagnosis of heart failure. It's unfortunately, it's progression. They go from half rev, EF 45% down to 30%. Or a lot of them they are non-compliant with their Lasix, or they're not compliant with diet, and then they get exacerbation. So, they will complain of shortness of breath, orthopnea, swelling. A lot of times they've been through enough exacerbations that they know, okay, it's my heart failure that's acting up again. You will hear crackles in your lungs, more repeating edema, your JVD, pretty typical stuff. And you can check for pro-BNP. I mean, a lot of attendings don't like correlating the BNPs. I mean, you don't really chase it, but sometimes I find it pretty helpful. If they kind of, they ride around 2,000 and then this admission you jump to 12,000, then something is wrong, right? You can check for that. Always check for MEG, potassium, BMP, basic metabolic panel, just because those patients are on diuresis and their K can be pretty low as a result of Lasix. So you need to know their recent echo, the reason for their heart failure. Sometimes it's ischemia, which makes sense. Sometimes it's non-ischemic. We just don't know, idiopathic. So you need to know that. You need to know who they follow or what's their regimen. Was it recently changed? So this is when usually, if there's frequent flyer, if they actually follow with a heart failure doctor, you should probably put a consult to heart failure for them to see while you give them more diuretics if they are they're volume overloaded. So basically, you should give them IV stuff. So if they're on Bumax PO at home, give them Bumax drip or IV Bumax. If they're on Lasix PO at home, you should probably give them Lasix IV. You do need to watch their kidney functions. What else? Keep them on heart failure medications. You know, sometimes they're on beta blockers. They are on ACE inhibitors. Some of them are on spirulactones. So you need to keep them on those medications. But sometimes, if they're in a cardiorenal, sometimes they are. If you diurese them, the kidney function actually gets better. So that's actually pretty cool. That's when you know, oh, this is not just AKI from pre-renal, it's cardiorenal. Really just diurese them. If heart failure consult, maybe get another echo, check for BNP, check for MAG, and check for the reason for their exacerbation. Sometimes, you know, most of the time it's non-compliance, like I said, but a lot of time, you know, it still could be, you know, some underlying causes like a new ischemic event, sometimes a fib, you know, that can throw someone into a heart failure pretty easily. So you need to look for that as well. And you do need to get a strict eyes nose. Keep them fluid restricted, like 2 liters. Salt restriction, 2 grams of sodium per day. Daily weight. You kind of, like with people with heart failure, with long history of heart failure, you know, they do have a dry weight. So you need to check how much weight they've gained, how far they are away from their dry weight. So you kind of have a goal. So heart failure doctor would say you keep diuresing until they're down to their dry weight. So that's kind of sometimes what you do. Okay, I think that's all I can think of for heart failure.